Question 1. Peripheral arterial testing. A 64-year-old male patient presents with intermittent claudication in his right lower extremity. During an ankle brachial index (ABI) test, the patient's right brachial systolic pressure is 104 mmHg and his right ankle systolic pressure is 7 mmHg. Based on these findings, what is the most appropriate interpretation? A. The patient has normal arterial circulation in the right lower extremity. B. The patient has moderate peripheral arterial disease PAD. C. The patient has critical limb ischemia. D. The patient has a falsely elevated ABI due to arterial calcification. Answer: B. The patient has moderate peripheral arterial disease PAD. Explanation: the ankle brachial index (ABI) is calculated as ABI systolic pressure brachial systolic pressure ABI 7 mmHg 100 for ml 0.50. ABI values are interpreted as follows: 1.0, 1.3, normal 0.9, 0.99, borderline 0.5, 0.89, moderate PAD 0.5, severe PAD, possible critical limb ischemia. Since the patient has an ABI of 0.50, this falls into the moderate PAD category. Incorrect options: A. Normal arterial circulation is incorrect because ABI of 1.0, 1.3 is considered normal. C. Critical limb ischemia is incorrect because this is usually diagnosed with an ABI 1.3 occur due to non-compressible vessels, not low ABI. Relevant guidelines and laws: American College of Cardiology (AC) and American Heart Association PAD guidelines recommend ABI testing for patients with suspected peripheral arterial disease. The Intersosa Accreditation Commission (IAC) vascular testing standards outline best practices for ABI measurement to ensure accuracy. Question 2. Venous testing. Which of the following Doppler ultrasound findings is most consistent with acute deep vein thrombus (DVT) in the femoral vein? A. Absence of spontaneous flow with vein incompressibility. B. Phasic flow that varies with respiration. C. Triphasic waveform with a sharp upstroke. D. Continuous high velocity flow in the affected vein. Answer: A. Absence of spontaneous flow with vein incompressibility. Explanation: acute DVT findings on venous duplex ultrasound include loss of compressibility, the most reliable sign of acute DVT, absent or reduced spontaneous flow due to obstruction of normal venous return, distended vein with low echogenicity clot seen in acute stages, absence of augmentation with distal compression, suggests proximal occlusion. Incorrect options: B. Phasic flow with respiration is incorrect because normal veins should demonstrate phasicity. Loss of phasicity may indicate proximal obstruction. C. Triphasic waveform is incorrect because this describes normal arterial flow, not venous pathology. D. Continuous high velocity flow is incorrect because acute DVT usually causes lower venous flow rather than high velocity flow. Relevant guidelines and laws: American Institute of Ultrasound in Medicine (AM) and the Society for Vascular Ultrasound (SVU) recommend venous duplex ultrasound as the gold standard for DVT diagnosis. American College of Chest Physicians (AC) DVT guidelines emphasize the importance of early detection and anticoagulation treatment. Question 3. Scenario-based. Abdominal and visceral vascular testing. Mr. Alvarez, 58-year-old patient with history of hypertension and smoking, presents with postprandial abdominal pain and unintended weight loss over the past 6 months. His physician suspects chronic mesenteric ischemia and orders mesenteric artery duplex ultrasound. The ultrasound findings reveal peak systolic velocity (PSV) of 350 cm in the superior mesenteric artery (SMA) and PSV of 200 cm in the celiac artery. Based on these findings, what is the most likely diagnosis? A. Normal mesenteric circulation. B. Significant superior mesenteric artery SMA stenosis. C. Celiac artery compression syndrome. D. Non-occlusive mesenteric ischemia (NOMI). Answer: B. Significant superior mesenteric artery SMA stenosis. Explanation: chronic mesenteric ischemia (CMI) occurs due to significant stenosis in the mesenteric arteries, SMA, celiac, and inferior mesenteric artery. Duplex ultrasound velocity criteria for SMA stenosis: PSV 275 cm. 70% stenosis. Mr. Alvarez's sub-PSV is 315 cm. indicating severe stenosis. Celiac artery v 200 cm may suggest moderate stenosis, but critical stenosis is typically at PSV 275 cm. Incorrect options. A normal mesenteric circulation is incorrect because sub-PSV 275 cm suggests significant stenosis. C. Celiac artery compression syndrome is incorrect because this condition typically presents dynamic celiac artery narrowing during expiration rather than a consistently high PSV. D. Non-occlusive mesenteric ischemia, NOMI, is incorrect because NOMI is due to hypoperfusion without fixed stenosis and typically occurs in critically ill patients. Relevant guidelines and laws. Society for Vascular Surgery, SVS, guidelines recommend duplex ultrasound as first-line, non-invasive test for chronic mesenteric ischemia. And College of Gastroenterology, AC, guidelines suggest intervention for symptomatic patients with small stenosis 70%. Question 4. Peripheral arterial testing. Ankle brachial index, ABI, and exercise testing. 67-year-old male. Patient presents with intermittent claudication, primarily in his left leg after walking for about 5 minutes. He has history of hypertension, hyperlipidemia, and smoking for 30 years. A vascular technologist performs an ankle brachial index ABI test. The resting ABI values are as follows. Right ankle, 1.0. Left ankle, 0.7. After exercise testing, the left ankle pressure drops to 0.5, while the right remains unchanged. What do these findings most likely indicate? A normal circulation in both legs, as ABI values above 0.7 are generally acceptable. B. Moderate peripheral arterial disease pad in the left leg with exercise-induced ischemia. C. Severe chronic venous insufficiency causing pressure fluctuations. D. An embolic event in the right leg despite normal resting values. Answer. B. Moderate peripheral arterial disease pad in the left leg with exercise-induced ischemia. Explanation. The ankle brachial index ABI is used to assess the severity of peripheral arterial disease pad. Normal ABI values range between 1.0 to 1.3. An ABI of 0.7 at rest in the left leg indicates moderate pad. A further drop to 0.5 post-exercise strongly suggests exercise and ischemia, meaning there is arterial obstruction that limits blood flow during increased demand. Option A is incorrect because although an ABI of 0.7 may not indicate severe pad at rest, the significant drop after exercise is a diagnostic hallmark of hemodynamically significant arterial obstruction. Option C is incorrect since chronic venous insufficiency does not typically cause a decrease in ABI values. Instead, venous disease is evaluated using reflux testing and venous duplex studies. Option D is incorrect because an embolic event would more likely cause an acute loss of perfusion, often leading to sudden pain and possible limb-threatening ischemia rather than a gradual exercise-induced drop in ABI. According to CFAHA guidelines for PAD, an ABI value of 0.7, 0.9 suggests moderate disease, while values below 0.5 suggest severe PAD. The exercise-induced drop supports the present claudication and hemodynamically significant arterial disease. Question 5. Venous testing. Deep vein thrombus (DVT) in the upper extremity. 42-year-old female patient presents with swelling, pain, and redness in her right arm over the past 48 hours. She has history of breast cancer and recently had central venous catheter placed in her right subclavian vein for chemotherapy. Venous duplex ultrasound is performed and the following findings are observed. Loss of spontaneous flow in the subclavian vein, incompressibility of the vein at multiple sites, lack of augmentation with distal compression, echogenic material seen within the lumen of the vein. What is the most likely diagnosis? A. Superficial thrombophlebitis of the cephalic vein. B. Deep vein thrombus (DVT) of the upper extremity. C. Chronic venous insufficiency secondary to lymphedema. D. Arterial embolism due to catheter-related complications. Answer. B. Deep vein thrombus (DVT) of the upper extremity. Explanation. The findings are highly suggestive of upper extremity DVT, particularly due to the presence of a central venous catheter, which is a well-established risk factor. Option A is incorrect because superficial thrombophlebitis typically affects superficial veins, such as the cephalic or basilic vein, and does not involve deep vein compressibility loss or echogenic thrombus in the deeper venous system. Option C is incorrect because chronic venous insufficiency and lymphedema present with non-compressible thickened veins, but without acute thrombus formation or sudden onset of symptoms. Option D is incorrect because arterial embolism presents with cold, pale, pulseless extremities, not the warm, swollen, erythematous presentation seen in this case. According to the American College of Chest Physicians Act guidelines, the presence of an indwelling catheter is a significant risk factor for upper extremity DVT, particularly in patients undergoing chemotherapy. Venous duplex ultrasound findings of incompressibility, augmentation, and echogenic thrombus confirm the diagnosis. Question 6. Scenario-based. Transcranial Doppler TCD and stroke risk. Dr. William is evaluating 58-year-old patient with history of hypertension, diabetes, and recurrent transient ischemic attacks. Tears. The patient is experiencing brief episodes of weakness on the left side and difficulty speaking, which resolve within 20 minutes. Transcranial Doppler TCD examination is performed, and the following findings are noted. Elevated mean flow velocities in the middle cerebral artery emici. Microembolic signals MES detected in the emici distribution. Presence of bidirectional flow in the ophthalmic artery. Based on these findings, what should Dr. William consider as the next step? A. Administer aromorhombolytics immediately due to high stroke risk. B. Perform carotid duplex ultrasound to evaluate for significant stenosis. C. Recommend aspirin alone as the only treatment for stroke prevention. D. Disregard the findings as normal and schedule follow-up in 6 months. Answer B. Perform carotid duplex ultrasound to evaluate for significant stenosis. Explanation. The presence of microembolic signals, MES, and elevated mean flow velocities in the emici are strong indicators of high stroke risk, often due to a significant carotid artery stenosis. Bidirectional flow in the ophthalmic artery suggests significant hemodynamic compromise, often from a severe stenosis or occlusion. Option A is incorrect because aromorhombolytics are only administered in acute ischemic stroke with persistent deficits lasting more than 24 hours. Tears resolve within 24 hours and do not meet this criterion. Option C is incorrect because aspirin alone is not sufficient treatment for high-risk patients with significant carotid stenosis. More aggressive antiplatelet therapy, endarterectomy, or stenting may be required. Option D is incorrect as these findings should never be disregarded. Delaying evaluation could lead to a major stroke. According to HUSA stroke prevention guidelines, patients with MES on TCD and suspected carotid stenosis should undergo imaging with carotid duplex ultrasound, CT angiography, MRI angiography to determine the need for carotid endarterectomy or stenting. Question 7. Lower extremity arterial testing. Segmental pressure interpretation. 72-year-old male patient with history of diabetes, hypertension, and coronary artery disease presents with bilateral leg pain while walking, which is relieved by rest. Segmental pressure exam is performed with the following results. Brachial pressure 104 mmHg right leg, high thigh 135 mmHg above knee, 125 mmHg below knee, 100 mmHg ankle, 85 mmHg left leg, high thigh 104 mmHg above knee, 135 mmHg below knee, 130 mmHg ankle, 120 mmHg. Which of the following is the most likely diagnosis based on the findings? A. Bilateral normal arterial perfusion with mild pressure variations. B. Right superficial femoral artery disease with significant stenosis. C. Bilateral iliac artery occlusion. D. Chronic venous insufficiency rather than arterial disease. Answer B. Right superficial femoral artery disease with significant stenosis. Explanation. Segmental pressures help localize arterial occlusive disease by comparing pressures at different levels of the limb. A drop of 20 mmHg between two adjacent segments suggests significant arterial disease. On the right leg, there is a 4 mmHg drop from the above knee to the below knee segment, indicating a hemodynamically significant stenosis, superficial femoral artery SFA. On the left leg, pressures are relatively uniform, suggesting no major obstruction. Option A is incorrect because the right leg pressures show a clear abnormality. Option C is incorrect as iliac occlusion would cause bilateral thigh pressure drops, which are not observed here. Option D is incorrect because venous disease does not cause pressure drops in arterial studies. The patient should undergo arterial duplex ultrasound or angiography for further evaluation. Question 8. Venous reflux testing. Chronic venous insufficiency CNI evaluation. 55-year-old woman presents with bilateral leg swelling and varicose veins. She reports heaviness and aching in her legs that worsens at the end of the day and improves with leg elevation. Venous duplex ultrasound is performed, revealing the following: great saphenous vein, GSV, reflux lasting 3 seconds in both legs, perforator incompetence in the calf region, no evidence of deep vein thrombosis DVT. What is the most likely cause of her symptoms? A. Superficial venous insufficiency with saphenous vein incompetence. B. Deep vein thrombus DVT causing secondary venous congestion. C. Acute arterial ischemia leading to venous stasis. D. Lymphedema rather than venous disease. Answer A. Superficial venous insufficiency with saphenous vein incompetence. Explanation: chronic venous insufficiency (CI) occurs due to valve failure in the superficial or deep venous system, leading to venous reflux and lower extremity symptoms. A reflux time 3 seconds in the GSV is diagnostic for superficial venous insufficiency (SVI). Option B is incorrect because DVT would cause non-compressibility of deep veins, which is absent in this case. Option C is incorrect since arterial ischemia presents with pain, pallor, and pulselessness rather than swelling and varicose veins. Option D is incorrect as lymphedema usually affects the dorsum of the foot and does not involve venous reflux. Treatment may include compression therapy, venous ablation, or sclerotherapy. Question 9. Carotid duplex. Identifying plaque morphology. 63-year-old man with history of hypertension and smoking undergoes carotid duplex ultrasound. The exam shows right icostenosis of 75% with heterogeneous plaque and irregular surface. Peak systolic velocity, PSV, of 320 centimeters in the right ICA. End diastolic velocity, EDV, of 120 centimeters in the right ICA. No significant stenosis in the left carotid artery. Based on these findings, what is the most appropriate next step? A. Start aspirin and statin therapy. Follow up in 6 months. B. Recommend carotid endarterectomy due to high stroke risk. C. Disregard the findings since there is no total occlusion. D. Repeat ultrasound in 1 year for reassessment. Answer B. Recommend carotid endarterectomy due to high stroke risk. Explanation: carotid stenosis of 70.99% with irregular plaque morphology is considered high risk for stroke. The PSV of 320 centimeters and EDV of 120 centimeters confirm severe stenosis. Option A is incorrect because while aspirin and statins are important, surgical intervention is needed for high-grade symptomatic stenosis. Option C is incorrect because severe plaque irregularity and high velocity suggest a high embolic risk. Option D is incorrect as waiting a year could lead to a stroke event before reassessment. Per ACFAHA guidelines, carotid endarterectomy is recommended for symptomatic patients with 70% stenosis. Question 10. Arterial waveform analysis in peripheral artery disease. PAD. A 68-year-old woman with diabetes and a history of PAD undergoes pulse volume recording (PVR) testing. The waveform shows monophasic flow pattern in the femoral and popliteal arteries, flattened waveforms in the tibial arteries, EBA of 0.5 in both legs. What do these findings suggest? A. Normal arterial flow pattern with mild variations. B. Severe arterial occlusive disease with reduced perfusion. C. Chronic venous disease rather than arterial insufficiency. D. Acute deep vein thrombus (DVT) affecting arterial waveforms. Answer B. Severe arterial occlusive disease with reduced perfusion. Explanation: monophasic waveforms and an HEPA of 0.5 indicate severe PAD with poor distal perfusion. The flattened tibial artery waveforms suggest significant stenosis in the lower extremity. Option A is incorrect as normal waveforms should be triphasic or biphasic, not monophasic. Option C is incorrect because venous disease does not cause waveform changes in arterial studies. Option D is incorrect since DVT does not affect arterial waveforms directly. The patient requires angiography to assess for possible revascularization. Question 11. Carotid stenosis. Doppler criteria interpretation. 70-year-old man with hypertension, diabetes, and history of transient ischemic attacks (TIAs) undergoes carotid duplex ultrasound. The findings include right ICA, peak systolic velocity (PSV) 420 centimeters, end diastolic velocity (EDV) 140 centimeters. ICACA ratio 5.5, left ICA ESV 170 centimeters, EDV 40 centimeters. ICACA ratio 1.7, What is the severity of stenosis in the right internal carotid artery, and what is the most appropriate management? A50, 69% stenosis. Start aspirin and statin therapy. B70, 99% stenosis. Recommend carotid endarterectomy. C, near total occlusion. Continue medical management only. D, no significant stenosis. Repeat ultrasound in 1 year. Answer B70, 99% stenosis. Recommend carotid endarterectomy. Explanation. The right ICA shows PSV 230 centimeters and an ICACA ratio 4.0, which suggests severe 70.99% stenosis based on Society for Vascular Surgery (SBS) guidelines. Carotid endarterectomy (C) is recommended in symptomatic patients with 70% stenosis. Option A is incorrect because PSV 400 centimeters and ICACA ratio 4.0 indicate severe stenosis, not moderate. Option C is incorrect because near total occlusion would show low flow velocities, not high PSV. Option D is incorrect as waiting could lead to stroke risk progression. Question 12. Chronic venous insufficiency (CEI). Venous duplex interpretation. 58-year-old woman presents with leg swelling, skin hyperpigmentation, and non-healing ulcers near the medial malleolus. Venous duplex ultrasound reveals great saphenous vein, GSV reflux, 5.2 seconds, small saphenous vein SSV reflux, 3.8 seconds, no deep vein thrombus DVT. What is the best initial treatment? A. Intravenous laser ablation EVLA. B. Graduated compression stockings and lifestyle modification. C. Surgical vein stripping. D. Oral anticoagulation therapy. Answer B. Graduated compression stockings and lifestyle modification. Explanation. CVI is diagnosed when venous reflux lasts 0.5 seconds on duplex ultrasound. This patient has superficial venous reflux, which is first managed with compression therapy, leg elevation, and exercise. Option A is incorrect because EVLA is reserved for cases refractory to conservative therapy. Option C is incorrect because surgical vein stripping is less preferred than minimally invasive procedures like EVLA or sclerotherapy. Option D is incorrect because anticoagulation is used for acute DVT or chronic venous disease. Question 13. Peripheral artery disease PAD. Treadmill testing. 65-year-old man with caudication in both legs undergoes treadmill test with segmental pressure measurements. Resting ankle brachial index ABI 0.72. Post-exercise ABI 0.50. Recovery time to baseline ABI 8 minutes. What do these findings indicate? A. Normal response to exercise. B. Moderate to severe arterial occlusive disease. C. Chronic venous insufficiency CVID. Small vessel disease without large artery involvement. Answer B. Moderate to severe arterial occlusive disease. Explanation. A drop in ABI of 20% after exercise with prolonged recovery time suggests hemodynamically significant PAD. Option A is incorrect because normal ABI does not drop significantly post-exercise. Option C is incorrect because CVI does not affect ABI measurements. Option D is incorrect since small vessel disease typically affects diabetics without large ABI changes. Question 14. Deep vein thrombosis DVT. Wells criteria application. 54-year-old woman presents with unilateral leg swelling and tenderness along the calf. Her Wells score is 3 and D-dimer is elevated. What is the next best step in management? A. Start anticoagulation immediately. B. Perform venous duplex ultrasound. C. Order CT pulmonary angiography (EPA). D. Reassess in 24 hours. Answer B. Perform venous duplex ultrasound. Explanation. A Wells score 3 indicates high risk for DVT, and the next step is venous duplex ultrasound. Option A is incorrect because anticoagulation should not be started without confirming DVT. Option C is incorrect unless there is suspicion for pulmonary embolism. P. Option D is incorrect because delaying diagnosis increases risk of complications. Question 15. Arterial duplex. Identifying arterial dissection. 45-year-old man presents with sudden onset leg pain and absent pulses in the right foot. Arterial duplex ultrasound reveals double lumen sign, flow reversal in the false lumen. What is the most likely diagnosis? A. Arterial embolism. B. Arterial dissection. C. Popliteal artery entrapment syndrome. D. Aneurysmal thrombosis. Answer B. Arterial dissection. Explanation. A double lumen sign with flow reversal indicates an arterial dissection where blood enters. A false lumen between arterial wall layers. Option A is incorrect because embolism causes acute occlusion without. A double lumen sign. Option C is incorrect because popliteal artery entrapment is a chronic condition. Option D is incorrect since aneurysm thrombosis would show no flow in the artery. Question 16. Abdominal aortic aneurysm. Surveillance guidelines. 67-year-old man with 4.3 centimeters infrarenal is seen for follow-up. What is the recommended surveillance interval for his aneurysm? A. Every 6 months. B. Annually. C. Every 3 years. D. No further follow-up needed. Answer B. Annually. Explanation. Per SVS guidelines, as between 4.0 4.9 centimeters should be monitored annually. Option A is incorrect as 6-month intervals are for as 5 centimeters. Option C is incorrect because 3-year intervals are for as 3.9 centimeters. Option D is incorrect since all as require surveillance. Question 17. A 68-year-old male with a history of hypertension, hyperlipidemia, and smoking presents with intermittent right leg pain that occurs after walking for about 5 minutes and resolves with rest. A vascular ultrasound and ankle brachial index (ABI) test are ordered. The ABI results are 0.68 on the right and 1.5 on the left. Which of the following best describes the patient's condition? A. Normal peripheral circulation. B. Mild peripheral arterial disease PAD. C. Moderate peripheral arterial disease PAD. D. Critical limb ischemia. Answer C. Moderate peripheral arterial disease PAD. Explanation. The ABI is a key diagnostic tool for peripheral arterial disease PAD according to the American College of Cardiology (AC) and American Heart Association (AHA) guidelines. Normal ABI 1.0, 1.40, mild PAD 0.91, 0.99, moderate PAD 0.41, 0.90, severe PAD limb ischemia 0.40. Since the patient's ABI is 0.68, this falls in the moderate PAD range. The classic symptom of claudication, pain with exercise relieved by rest, also supports this diagnosis. Critical limb ischemia, which would be associated with ABI 0.40, typically presents with rest pain, ulcerations, or gangrene, which are absent in this case. Question 18. During a carotid duplex ultrasound, a peak systolic velocity (PSV) of 320 centimeters and an end diastolic velocity (ED) of 135 centimeters are recorded in the internal carotid artery. How should this be interpreted? A. Normal carotid artery flow. B. 70% stenosis. Answer D. 70% stenosis. Explanation. Velocity criteria are crucial in carotid duplex ultrasound to determine the severity of stenosis. The Society for Vascular Ultrasound (SVU) criteria suggest normal 50% stenosis, PSV 125 cm, EDV 70% stenosis, PSV 230 cm, EDV 100 cm. Since the patient has PSV of 120 cm and EDV of 135 cm, this meets the criteria for 70% stenosis, indicating high risk for stroke. Question 19. Scenario-based question. Mr. Thompson, a 55-year-old diabetic, is undergoing a renal artery duplex ultrasound due to persistent hypertension despite multiple medications. The sonographer notes a renal to aortic ratio (RA) of 3.8 and peak systolic velocity (PSV) of 240 centimeters in the right renal artery. Based on these findings, what is the most likely diagnosis? A. Normal renal artery flow. B. 60% stenosis. D. Renal artery thrombosis. Answer C. 60% stenosis. Explanation. The renal to aortic ratio (RA) is an important diagnostic parameter in renal artery stenosis. Normal RA 60%, RA 3.5 and PSV 200 cm. Since the RA is 3.8 and PSV is 240 cm, this meets the criteria for 60% renal artery stenosis, common cause of secondary hypertension. Artery thrombosis would show no detectable flow rather than increased velocity. Question 20. A patient with suspected deep vein thrombus DVT undergoes a lower extremity venous duplex ultrasound. The exam reveals lack of compressibility in the common femoral vein, hypochoke material within the lumen, and spontaneous but reduced flow on Doppler. What is the most appropriate interpretation? A. Acute deep vein thrombosis. B. Chronic deep vein thrombosis. C. Normal venous flow. D. Superficial thrombophlebitis. Answer A. Acute deep vein thrombosis. Explanation. Key ultrasound findings of acute DVT include non-compressibility of the vein, gold standard for DVT diagnosis, hypoechoic thrombus, less echogenic than chronic thrombi, spontaneous but reduced venous flow. Chronic DVT would show echogenic thrombus, vein wall thickening and recanalization. Superficial thrombophlebitis affects superficial veins, e.g. great saphenous, whereas DVT affects deep veins like the common femoral veins seen here. Question 21. A transcranial Doppler TCD ultrasound detects retrograde flow in the left vertebral artery. What is the most likely cause? A. Normal vertebral artery flow. B. Carotid artery stenosis. C. Subclavian steal syndrome. D. Intracranial hemorrhage. Answer C. Subclavian steal syndrome. Explanation. Subclavian steal syndrome occurs when a proximal subclavian artery stenosis causes blood to reverse in the vertebral artery to supply the arm. Key findings: retrograde vertebral artery flow, blood diverted from the brain to the arm. Symptoms like arm claudication, dizziness, or syncope. Carotid stenosis affects anterior circulation, not the vertebral artery. An intracranial hem does not cause retrograde vertebral flow. Question 22. A patient undergoes an ultrasound for suspected abdominal aortic aneurysm A. The maximum diameter of the abdominal aorta measures 5.3 centimeters. What is the best management? A. Observation with annual ultrasound. B. Immediate surgical repair. C. Follow-up ultrasound in 6 months. D. Start anticoagulation therapy. Answer C. Follow-up ultrasound in 6 months. Explanation. Our management guidelines, SVU and Society for Vascular Surgery, state 5.5 centimeters. Consider surgical repair. Since this A is 5.3 centimeters, the best option is close monitoring with follow-up in 6 months, unless rapid growth occurs. 0.5 centimeters in 6 months. Question 23. Which of the following artifacts in vascular ultrasound is caused by a strong reflector such as bone or calcified plaque? A. Mirror image artifact. B. Aliasing artifact. C. Acoustic shadowing. D. Color bleeding. Answer C. Acoustic shadowing. Explanation. Acoustic shadowing occurs when strong reflectors, bone calcifications, block ultrasound waves, creating a dark shadow behind the object. Aliasing occurs in Doppler imaging, and mirror image artifact is due to sound wave reflection. Question 24. A patient presents with bilateral leg swelling and heaviness. A venous reflux study shows reversed flow for 3.5 seconds in the great saphenous vein. What is the most likely diagnosis? A. Chronic venous insufficiency. B. Acute deep vein thrombosis. C. Lymphedema. D. Normal venous function. Answer A. Chronic venous insufficiency. Explanation. Venous reflux 0.5 seconds confirms chronic venous insufficiency, CI. Lymphedema has non-pitting edema and normal venous flow. Question 25. Which of the following describes the most appropriate Doppler angle for vascular ultrasound? A. 0 degrees. B. 30 degrees. C. 60 degrees. D. 90 degrees. Answer C. 60 degrees. Explanation. The ideal Doppler angle for vascular studies is 60 degrees to avoid velocity overestimation. 90 degrees would produce no Doppler shift, and 30 degrees increases artifact risk. Question 26. A 72-year-old female with a history of diabetes, hypertension, and coronary artery disease presents with a non-healing ulcer on her left great toe. A vascular ultrasound and toe brachial index (TBI) test are performed. The TBI is 0.28 and Doppler waveforms in the dorsalis pedis arteries show monophasic flow with low amplitude. Based on these findings, what is the most appropriate next step? A. Conservative wound care with close follow-up. B. Referral for arterial revascularization. C. Start anticoagulation therapy. D. Recommend increased physical activity. Answer B. Referral for arterial revascularization. Explanation. The toe brachial index TBI is an important diagnostic tool, especially in diabetic patients where the ankle brachial index AB may be falsely elevated due to calcified arteries. Normal TBI 0.70, moderate ischemia 0.31, 0.69, severe ischemia, critical limb ischemia CLI 0.30s. TBI 0.28, indicating severe ischemia, and the Doppler waveform is monophasic. The patient has critical limb ischemia, CLI. The best course of action is referral for arterial revascularization to prevent amputation. Question 27. A 45-year-old male truck driver presents with right upper extremity swelling and pain that worsens with activity. A venous duplex ultrasound shows non-compressibility and increased echogenic material in the subclavian vein, along with retrograde flow in the external jugular vein. What is the most likely diagnosis? A. Paget-Trota syndrome, effort thrombosis. B. Superior vena cava syndrome. C. Axillary subclavian venous reflux. D. Deep vein thrombose, DVT, of the lower extremity. Answer A. Paget-Trota syndrome, effort thrombosis. Explanation. Paget-Trota syndrome, also called effort thrombosis, is a type of upper extremity deep vein thrombosis associated with repetitive arm movements, e.g. truck drivers, athletes. Key findings: thrombosis of the subclavian or axillary vein swelling and pain, worsened by arm activity, retrograde flow in collateral veins, external jugular cephalic vein. This differentiates from superior vena cava syndrome (SVCS), which typically causes bilateral swelling and is related to malignancy. Question 28. During a lower extremity arterial duplex ultrasound, a 50-year-old male smoker is found to have a popliteal artery aneurysm measuring 2.5 centimeters in diameter. He is asymptomatic. What is the most appropriate management? A. Annual surveillance ultrasound. B. Follow-up ultrasound in 6 months. C. Immediate surgical repair. D. Anticoagulation therapy. Answer B. Follow-up ultrasound in 6 months. Explanation. A popliteal artery aneurysm, PARP, is the most common peripheral artery aneurysm and is associated with high risk of embolization, thrombosis, and limb ischemia. Management is based on size and symptoms. 3 centimeters or symptomatic, consider surgical repair. Since this aneurysm is 2.5 centimeters and asymptomatic, the best option is follow-up in 6 months. Assess for growth. Question 29. A 67-year-old patient with atrial fibrillation presents with sudden onset of right leg pain, pallor, and pulselessness. A duplex ultrasound shows high resistance, absent flow in the common femoral artery. What is the most likely cause of the symptoms? A. Acute arterial embolism. B. Chronic atherosclerotic occlusion. C. Deep vein thrombose, DVT. D. Popliteal artery entrapment syndrome. Answer A. Acute arterial embolism. Explanation. This patient presents with the classic 6-piece of acute limb ischemia, OLI, pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia, cold limb. In patient with atrial fibrillation, acute arterial embolism is the most likely cause. The duplex ultrasound confirms high resistance, absent flow, which suggests sudden occlusion rather than chronic stenosis. Immediate intervention, embolectomy, thrombolysis, is required to prevent limb loss. Question 30. A patient with chronic venous insufficiency (CNI) undergoes a venous reflux study. The great saphenous vein (GSV) in the thigh demonstrates retrograde flow lasting 3.2 seconds after augmentation. What is the best interpretation? A. Normal venous function. B. Superficial venous insufficiency. C. Deep vein thrombus, DVT. D. Venous outflow obstruction. Answer B. Superficial venous insufficiency. Explanation. Venous reflux studies assess for chronic venous insufficiency (CEI) by measuring valve incompetence. Normal reflux duration 0.5 seconds. Deep venous insufficiency 1.0 seconds, since the reflux lasts 3.2 seconds. This is diagnostic of superficial venous insufficiency. It can lead to varicose veins, leg swelling, and venous ulcers if untreated. DVT show vein non-compressibility, not reflux.